So we're getting ready to go live for tonight's COVID-19 and coronavirus program is on children and coronavirus. Let me see if I can go into presentation mode. The New England Journal covered an article where they basically looked at children in the first country that was really hit with coronavirus, obviously China. They followed children in the Wuhan Children's Hospital. And they took a look and saw, what were the infection rates? And the infection rates were significant. What were the disease rates? Not very much. As you begin to fast forward that and look at other countries, what, 627? I think Clyde just told me that Al Jazeera, one of the Muslim world news feed mentioned 627 deaths today, past 24 hours from COVID-19 in Italy. And another announcement indicating that children were clearly a significant part of the transmission cycle. When you go back and look at the New England Journal article, it's clear that children are a significant part of the transmission cycle, but fortunately not getting hit that hard with the disease itself. Now, we'll cover that in more detail in just a minute. We'll also do some update on things like what's going on in the US, what's going on in the US with testing. As we'll see with the CDC, they're saying the guidelines for testing with the CDC are set up to, no other way to phrase this other than to say they're set up to discourage testing right now. That sounds like, the CDC is catching a lot of grief right now for a whole bunch of reasons. And one of them would and should be discouraging testing. Once you begin to dig a little bit deeper, though, you see that what would you do if you're in the CDC and you're responsible for handling healthcare policy for this country, and there is no availability of coronavirus testing? Are you going to encourage it? All you're going to do if you do that is just create more panic, more emotion in this very emotional time for a lot of people, where so many people are just now beginning to wrap their head around the fact that, yes, we do have a pandemic. And yes, it's just been over the past couple of days that we've finally began to get kids who were still taking spring break down in Fort Lauderdale and Miami on the beaches. They're finally beginning to get serious about this. And, it's very interesting. You see that people that are not tuned into this ignored it for a couple of weeks, while many of us have been on isolation and lockdown, whatever you want to call it. There are distinctions between those, but social isolation for a couple of weeks already. Others were just saying, you know what, this is not for young people. I don't need to worry about it. That's crazy. And then all of a sudden, now they're getting forced to go into lockdown. But so they're going from totally ignoring it to panic, neither of which is appropriate. We can manage our way through this, and we will manage our way through this. I think the US is going to do fairly well based upon what we've already begun to learn from China, from Italy, from South Korea. But again, we have to think appropriately, not panic, but think. We've provided a couple of links. I'm going to see if I can provide another link here. This one is on confirmed coronavirus cases growing faster in the United States than any other country in the world. Well, that's right now, that sounds scary. But again, let's not get afraid. There's no reason to. You may think I'm crazy. I'm not. There is no reason to. We will get through this. And in fact, there's plenty of reason not to panic. Let me see if I can go back, escape out of InShow, and provide a link on the comments.
Afraid there's no reason to. You may
gosh.
think I'm crazy. I'm not. There is no reason to. We will get through this. And in fact, there's plenty of reason not to panic. Let me see if I can.
So hopefully we didn't blow things up, Clyde, when we did that. I'm going to go ahead and provide a link to the
Yeah, sure, Doc. I think you just solved that. I think you closed the YouTube, another tab, but it's okay now.
Okay. So let's go back out. So Clyde, we're still in presentation mode. Is that correct?
That is correct.
Okay, so we're going to go back out and do the standard presentation for tonight. And it has to do with kids, children, and coronavirus. If I can find it. Here we go. So let's go back to presentation mode. Again, as the world is getting more and more serious about dealing with this pandemic, as it's becoming clearer and clearer that folks that were ignoring the pandemic are really starting to take it seriously. Those folks who are not that in touch with it are again risking going from ignoring it, pendulum swinging all the way over to panic. No need, we're going to get there. In fact, plenty of need not to do so. One of the short but sweet stories in this world, or in this phase, in this activity, has to do with children. This was a New England Journal, SARS-CoV infection in children. It was published, gosh, it was last week. Let me just go through the details on it. 72,314 cases reported by the Chinese CDC as of March 20th, 2020. Less than 1% of those were children less than 10 years old. They evaluated children treated in Wuhan. Obviously, that is the only. It's not. Maybe most of us in the West don't know this, but there is one children's hospital in that area, and that is the Wuhan Children's Hospital. They evaluated these children for SARS-CoV-2, which is the coronavirus that's causing a pandemic right now. They looked for children with both symptoms and kids that were infected and had no symptoms, we call asymptomatic. They did nasopharyngeal swabs and throat swabs as well. Just by the way, as things have continued to develop, we're working on a project for a large national retailer right here, and things have developed such that throat swabs are not recommended anymore. It's nasopharyngeal swabs. In other words, it's a swab that goes through the nose. It's uncomfortable, but you get over it. Now, let's go back to the study that we're talking about the first country and kids and their involvement in this pandemic. They monitored the medical outcomes up through March 20th when they closed off the study to prep it for publication. Here's what they found. There were 1,391 children assessed and tested. It started in January 28th and ended in February 26th. There were 117, or 12.3% of these children were infected. The median age was 6.7 years. 41.5% had fever. Cough and sore throat were very common among these kids. 27 patients, 16%, had no symptoms at all, yet they were infected. 12 had X-ray signs of pneumonia. But again, you see this over and over. This is the theme with kids. Yes, they do appear to get infected for sure. And actually they are part of the transmission chain, but little to no illness or symptoms. Now, there were 3 kids out of that group of what, 1,300, 1,400 that were in the intensive care unit. But these kids were actually in the intensive care unit for other reasons. One for leukemia, one for intussusception. What is intussusception? It's a very serious problem where the the intestine has gone inward on itself and come back out, and one for hydronephrosis. So again, these were all the things that put those 3 kids in ICU, not the COVID-19, not the coronavirus. Lymphopenia was seen in 3.5%. What's lymphopenia? Again, it's a large medical word. You don't need to worry about it. Basically, lympho means that it's lymphocytes. That's part of one of the family of immune cells. And penia, as always, is a suffix meaning a low amount or a lack of. So 3.5% of kids demonstrated significant reaction within their immune system. You saw it in evidence on their chest X-ray, a ground glass appearance. And in fact, that was even far more common. About 1/3 of these kids showed this ground glass appearance on their chest X-rays. So very, very interesting point. And as most of us know, when COVID does kill and when it does get lethal, it has to do with causing severe reaction within the lungs, a severe inflammatory reaction. So these kids do have an impact within their lungs, but not like adults. It's not something that's killing them. It's not even causing symptoms. So infected, here's the summary of the whole thing. Again, it's a short but very sweet story for tonight. Infected children have a milder course. Okay, so we're going to go through some other things. Tomorrow night, Janice has referred to some of the videos that we're doing now as the daily. What's that? The fireside chats. As you see, I have no fire up here, and I'm certainly no FDR Roosevelt, but we're committing right now, as long as this is such a hot topic, to start providing the science, updates on the science, key stories on what's going on with coronavirus. Tomorrow night, we'll be presenting a trial of Lopinavir Ritonavir in adults hospitalized with severe COVID-19. You probably never heard of either one of these unless you happen to be in the space. These are both medications that are used. It's one of them is called like a protease inhibitor. What is that? Don't need to know that. But these are medications that are successful in the treatment of HIV. They're virus, antivirals. And again, we'll go into the details of what they found in terms of doing a clinical trial with these viruses. Obviously, it's incredibly important because no therapeutics have been found yet or proven effective for the treatment of severe COVID. So that gives you a little bit of information regarding what's up for tomorrow. Let me just go in and see if we have any comments and deal with those, and then come back out and maybe deal with updates on a few other topics like zinc, quercetin, chloroquine, hydroxychloroquine, ACE inhibitors, ARBs, baby aspirin for cardiac, for heart attack and stroke, non-steroidals, acetaminophen, some of those things. But let's go back out first and take a look and see if we have any interest, any participation out there. Okay, we've got a lot of people. Let me go back and take a look at the group here. Bart Robinson joined early, got the email alert and my full attention. Thank you, Bart. Very interested in hearing your comments tonight. Hi, Dr. B, ready, Dr. Brewer, Miami, Florida. So in Miami, again, finally decided to close down the beaches, and it is inestimable, if that's a word, how much transmission occurred on the beaches in Fort Lauderdale and in Miami. and in the bars and restaurants as an aftermath of that boondoggle or debacle. Robin Ray, my 28-year-old daughter just finished 9 months of chemotherapy. Very scary for us. She has no immune system because cancer therapy is terrible. There's no question. Our thoughts and prayers go out to you, Robin, and your daughter. Tom Robertson, modeling my mini shows, closing schools when one case shows up. Saves 25% of something deaths. Again, we put in a couple of references regarding, again, 627 deaths in Italy today. Children, a significant part of the transmission chain, and the rapid acceleration of cases in the United States right now. Again, all of this is very interesting news. It's enough to perk up your ears, but not enough to make us panic. Panic is the worst thing we can do right now. And again, not only is there no need, it's dangerous to do that. What about morbidity in children, lung scarring? I think it's way too early to tell if these kids, like you, I mean, that was Ken Patu. Thank you, Ken Patu. And I think it's way too early to tell how much, like we said, a third of those kids had evidence of that ground glass appearance on X-ray. What is that going to look like a year from now, 2 years from now, 10 years from now? Are they going to be more at risk for chronic obstructive pulmonary disease, lung disease? It's too early to tell. I'm personally very optimistic because these viral diseases, if they don't kill you, tend to not cause a lot of long-term problems. But let's get past the acute phase first. A. Ballard, 527. I had one doctor recommend melatonin supplements if you get sick. What do you think? A. Ballard, I think that's a great question, but I have to tell you, I've been living and breathing the science of what kills you for a long time. And so the past few months after, or past couple of weeks after our Orlando event, I've been living and breathing the science of COVID-19 and coronavirus. This is the first time I've heard any mention about melatonin. So I'm skeptical that melatonin is going to turn out to be a player. Derek Stagima, hi, Dr. Brewer. Should older parents consider keeping their elementary school kids at home in the event that schools reopen in their jurisdiction sometime in April? Not exactly sure what the significance of older parents is, some of the other stuff. As you may remember, Derek, first of all, thank you for the comment. And as you may remember, I recommended closing the schools at a point when that was not a very popular suggestion. I don't understand. I think what you're asking is, should you keep your kids out longer than is recommended if the schools open back up? That's a good question. I haven't really thought through it yet. Obviously, those of us who are in our 60s, those of us who have high blood pressure, heart disease, diabetes, we do have increased risk. And I think that may be what you're getting at. I think those are significant considerations. Don't have an answer just yet. Again, I think I have to think some more through that. That's a significant point. If you've got kids going to school, yes, kids are likely to be a significant part of transmission. They are in almost any of these viral outbreaks. It may not harm them in this case, but may create significant risk for you. So as I'm thinking through this, I think you're bringing up a very good point. Brett L., any news about hydroxychloroquine? Yes.
Yeah, before you go into the next question, do you mind stop sharing your screen? I'm not currently there we go. Thank you.
Thank you, Clyde. Are you able to put the image up? Let me see if I can go back. Okay, thanks. Clyde, we need to make you co-presenter.
Co-host, yeah.
And maybe remind me the next time we're for the next event.
Sure, Doc.
So Brett L., any news about hydroxychloroquine and azithromycin? So yes, it's the more things develop, the more hydroxychloroquine and azithromycin are looking like real potential players in this in this play. I'm not going to go back and try to find the slides. I've done a couple of series, a couple of updates on hydroxychloroquine. Now, where does hydroxychloroquine fit? What is it, and how does it fit in this picture? And what does azithromycin have to do with it? Not so much on azithromycin right now, although it does appear to have some significant potential significance. Hydroxychloroquine is Plaquenil. It's an age-old antimalarial. It's also given quite often now for people that have some of the inflammatory diseases such as lupus and even arthritis, rheumatoid arthritis, you know, that makes people's hands, joints go like that. It's where your body's attacking itself. They also happen to be what we call a ionophore. What's an ionophore? An ionophore is something that helps zinc get into the human cell. Interesting thing about zinc, it does appear, I mean, there was a story that was hidden for a while. It was by a virologist that's done a lot of work with coronavirus. He was sending a message to his family and friends to say, as coronavirus kicks up, I've done work in it, and I can tell you, zinc helps. It helps decrease coronavirus infection. That went, no pun intended, that went viral. Sorry. So you developed a lot of interest in zinc. I routinely take zinc for other reasons. And it's so interesting. I was going to show that tonight and forgot totally about it. It's at the other end of the house. I ran out of zinc, so I was flat out of luck on my zinc for a few days. Weird thing happened. I got a package yesterday from Amazon, and it was a refill on my zinc. So very interesting. Anyway, so zinc appears to be a potential player. Now, where does zinc come in? Well, it has to do with an enzyme, and it has to do with proliferation of the virus once it gets into your body. The virus is dependent on an enzyme called, hold on, RNA-dependent RNA polymerase. So first of all, what is RNA? This is what we call an RNA virus. There are some DNA viruses, but more viruses are RNA dependent. It's the genetic material. We use DNA, more viruses use RNA. The coronavirus is an RNA virus. So it gets into our cell and it hijacks our genetic material development systems. One of the things that it does is it hijacks RNA-dependent RNA polymerase. Again, you don't need to remember all that long word. But what you do need to remember is the mechanism. So it starts using our cells' capacity to develop genetic material. The genetic material, as you know, tells us what proteins to make. It basically controls, it's the control center of the cell. So the virus takes over the control center of the cell. Now, in order to do that, it has to hijack that enzyme, and zinc slows that down. It inhibits or slows down that enzyme that this virus uses to hijack the mechanism for taking over our genetic materials. Now, let's go back again one step and talk about the chloroquine. Chloroquine is an antimalarial that's even older than hydroxychloroquine. What we found out was that there's a connection between chloroquine, hydroxychloroquine, and zinc, and it has to do with that term called ionophore. Zinc is an ion. It's if you look at it chemically for the geeks out there, and there's a lot of them, it has a 2+, meaning that it's a 2+ positive, meaning that it gives up 2 electrons, meaning, again, a bunch of geeky stuff that you don't need to remember. However, because of that, it has a hard time getting through the cell membrane, because the cell membrane is made up mostly of fats and oils. So if you've got, you can take all, I can go back and get that zinc that just arrived today, and I can take a lot of it. I can get very high levels of zinc in my bloodstream, but it really doesn't do that much good until and unless the zinc can get inside the cell membrane. And that's where chloroquine and hydroxychloroquine and the term ionophore come in. Those are ionophores. Now, there have already been some studies which looked at chloroquine, hydroxychloroquine, and yes, they did appear to help. And yes, I have already written some prescriptions for hydroxychloroquine for, I've got a couple of docs that are patients of mine. One, for example, is an ophthalmologist. He's unable to go into social isolation. He's still having to see patients. And guess what? I've got a few docs that I'm associated with that are ophthalmologists. And one of the key presenting symptoms of COVID-19 is irritation and redness of the eyes. So these guys are right there at the tip of the spear. You know, they're seeing redness of the eyes. They don't know if they're seeing COVID-19. They cannot, because of their work and the nature of their work, they cannot back away and go into social isolation. A couple of them have asked me for hydroxychloroquine. We've had several people ask me about the dosage levels. There are a whole bunch of different dosage levels used. One of the more popular dosage levels is 200 milligrams per day. That's what we're using right now. Is that going to turn out to be the best? We don't know. We just don't know at this point. But that's what we are using right now. We're open to any better suggestions. Hydroxychloroquine and chloroquine, these are both not innocuous drugs. They're not like metformin, where if they were being evaluated today by the FDA, they might even be made, metformin might even be made over the counter. Not so with chloroquine and hydroxychloroquine. You have significant potential for significant damage of the retina of the eye and even full-blown blindness. But, you know, there's always good news, bad news situations. The good news piece of that is that tends to happen more after like 5 years of use of hydroxychloroquine. That's, you see that again with people that are on this for things like lupus. So again, a little bit of story and back follow up on the zinc ionophore hydroxychloroquine message. Before we get too deep into questions, we'll cover a couple of other things. Taking baby aspirin for heart attack and stroke prevention. Do not recommend that you change that. Continue to take your 81 milligrams, your baby aspirin for heart attack and stroke prevention. How about non-steroidals, Advil, Motrin, which a lot of people take for the common cold? Well, again, COVID presents originally usually as the common cold, you know, red eyes, irritation of the throat, which we saw, and I don't think I mentioned, but I had it it was in the study on kids in China. These kids tended to have a sore throat and red eyes and stuff like that. A lot of people take non-steroidals for that, Motrin and Advil. Not recommended. Again, there could be a different ending to this story, but every indication right now is that those are non-steroidals, anti-inflammatories. What does anti-inflammatory mean? It means it slows down your immune system. And in slowing down your immune system, it very much does appear to risk decreasing your ability to clear this virus. So then that whole group of topics then ends up with acetaminophen. Is acetaminophen a problem? It's not a non-steroidal. It's not an anti-inflammatory per se. Is it safe? And yet the answer is yes. At this point, acetaminophen does appear to be a much better choice. Or you could go like me. I mean, I get sick, I get a cold, and I just drink hot tea and run smack into it and go to bed and feel bad for a few days. Okay, so oh, the one thing that we haven't, one of the key items, one of the maybe the most important current clinical items that I haven't discussed yet in terms of an update is this. I did a couple of videos today on the CDC fact sheet for coronavirus testing. Here's the thing, the CDC has been criticized, and I think rightly so, but not really, in terms of their recommendations around coronavirus testing. If you look at countries like China and Italy, obviously they had a huge, they're in hot water, had a lot of deaths associated with not dealing with this virus up front very quickly. Well, you know, they were guilty of a lot of stuff, but some of the stuff was they just didn't know. South Korea, on the other hand, has a very flat curve. And South Korea was doing a boatload of testing coming out of the blocks. Now, go back over to the US and the CDC, the United States CDC. Again, currently still their recommendations are pretty low, pretty restrictive. You can't really phrase it as anything other than being pretty restrictive on testing. I do expect that to change. Here's why. And think about it. You're in a country where you've got, what, 300 million people. They're finally wrapping their head around coronavirus, 100-year pandemic. And here's the thing, there just aren't any tests out there now. There aren't significant test kits. As I mentioned a few times, we're working in partnership with a globally known logistics company, a globally known retailer, a globally known lab to start offering coronavirus testing. So it perked our interest when we saw a local University of Cincinnati testing program. So they went out and they took a look, and what happened was it looked like there were, what, less than a dozen tests done. I mean, you had more people out there running the program than you had tests done all day. Well, why was that? Because they could not access the test kits. So if you're in charge of policy for this specific testing program for the CDC, what do? You tell all these people to go get tested? No, there's no test kits available. Well, the other side to that is we're pretty comfortable that testing is going to become widely available in the US within a week, 4 or 5 days, as in potential for thousands of test kits per day available. So once that happens, I do expect the CDC recommendations regarding testing to change significantly. If you go in and read the fact sheets and the recommendations for testing with the CDC right now, basically what they do is they start off with a testing discussion and they say, you know, testing should be available and done for people that are in the hospital with COVID, for healthcare providers that are providing care for people with COVID-19. And that's about it. They do start to talk about people like us, the baby boomers with significant diabetes, heart disease, high blood pressure, those things. But then it goes back and it says, it again re-specifies the people with risk factors and says, if you're involved in an area which has transmission, if you're caring for people in a nursing home. Again, so many conditions to where it almost starts to lock you back out of testing. What it's doing is taking you back to very simple, logical information. If you have, if you're losing your ability to breathe, if your face is turning blue, if your lips are turning blue, if you're having major chest pain and can't breathe very well, forget about the test and go get emergency care. Well, yeah, that's true. If you have moderate symptoms, go home and take care of yourself. Don't get tested. That's the way it's set up right now. And again, I understand why that's the case. If I were running this policy for the CDC and I didn't have any test kits available in the US, I'd have a similar type of policy. Now, many people have gone in and criticized the CDC for not having a lot of test kits out there. And, you know, I don't know the story behind that. I'm sure there's blame to be thrown around. And I'm sure that would help a whole lot, finding people to blame for stuff. Eduardo Salcedo, let's go with some questions now, thanks. Ready, thank you, Eduardo. Dr. Brewer, Miami, Florida, thanks, glad to hear you're from there and glad to hear they closed down the beaches. Robin Ray, we talked about your daughter, again, our prayers out to her. Tom Robertson, modeling by many shows, closing schools when one case shows up. Well, when one case shows up, what is that? A dozen, 2 dozen, 100 infections that have already happened. I don't think I'd wait for that one case to show up. That's a very common theme in terms of school closing. Wait till a case shows up. Don't think I would do that. Yeah, Tom Robertson saves 25% of the deaths. You know what, again, I think if you don't wait till that one case shows up, you can save a lot more than 25% of the deaths. So thank you for your comments. Please reconsider that policy. Ken Patu, what about morbidity in children? We talked about that. Ballard recommended melatonin. We talked about that. Brett L, how about, okay, we talked about that. Kevin Dixon, where can info be found about the deaths in Italy to include children? We sent something out recently, and I mean, if you go back and look at that link, I think that will help. A Ballard, N-acetylcysteine, NAC for lung support, thoughts? Yep, I've done research on NAC, got several videos on it. Those were all prior to the to the coronavirus outbreak. So I don't have anything specific to NAC and coronavirus, but I do have some old videos, as in 6 months old, involving N-acetylcysteine. N-acetylcysteine is something that we use in the ERs for things like overdose on acetaminophen. Won't go down that bunny trail. Robin Ray, how can we build a daughter's immune system or protect her during this time? I think the major thing for protecting her is isolation. John Little, do ARBs increase? And again, I know there's a lot of desire and there's a lot of information and a lot of focus on trying to build the immune system. And in fact, I'm very disappointed to find one of the, a YouTube doc who I respect because of her focus on keto diet, but recently is advertising and talking about traveling because her family's immune system is very protected with keto. Again, we're not talking about 50-year-old parents and 20-year-old kids and their immune system health. We're talking about catching a virus to continue the chain of transmission. That's what works. We're not talking about immune system function, although that's a critical piece. You can't build your immune system over the next 2 weeks to fight the virus. That's not a great tactic. That's not a great plan. The plan that does work is quarantine, keeping the virus from inside your home. So think about those elective surgeries. Think about going out to eat. Think about In fact, I wanted to cover a few questions. My wife, Janice, as you know, is very involved in our activities, and she had a few questions that she wanted to make sure that we covered. One of them I just walked into. She hears this a lot. Quote, I'm being really careful with social isolation because I'm so glad that a local chef is offering takeout. A lot of restaurants all over the place are closing, and then they're offering takeout. I actually had a viewer make a comment that, well, Brewer, some people are going out and shopping for groceries. I'm getting takeout every night. Isn't that better? Think about it. You get takeout every night, or for one meal, maybe 2 meals, maybe you spread it out over 2 meals, but you're ordering the food, they're bringing it over. At least have them leave it on the door. But you know, how are you going to pay for it? You're going to be in the breathing space of you and whoever delivers that food. And you're going to do that at every meal, as opposed to going to the grocery store once for hopefully a month's worth of food. So I'm not a big fan of takeout right now. I mean, it's obviously better than going and sitting down in the restaurant. But here's another thing that we haven't talked about yet, and that is, so the restaurant industry is pretty notorious for not doing the greatest job in terms of screening. I mean, how can they screen all of their employees who are prepping the food? So how do you know what's on the food that you ordered for takeout? Admittedly, it appears to be more aerosol transmitted than anything else, but I don't think anybody is saying, oh, you don't have to worry about the food you eat and whether or not it has coronavirus. One thing we do know, for example, is that the reason they call it coronavirus is those proteins that stick out from the virus. And one of the things that I hope to cover sometime soon is a recent article in Nature magazine. It's talking about why coronavirus is so contagious, so infective. It's those little proteins that stick out. And the point is, they can cause infection not only just from aerosol, but from the intestines as well. So that brings you back to this common misperception. Well, I'm safe because I'm ordering food out. I'm getting takeout. Okay, another one that Janice asked us to cover is, I don't know anyone with COVID-19, so I can't have it, right? Oh, I mean, so many of these misperceptions. She hit the nail on the head. It's like the kids that went on spring break in Miami and Fort Lauderdale. I don't know anybody with COVID-19, so that's not in my world. That's for the old folks. Well, we're in the early stages of this 100-year pandemic. And here's why it's a pandemic. I haven't seen the numbers, I haven't seen an analysis yet, but everything that I look at points to the vast majority of this transmission being done by people who don't know that they have the virus. There was another article, again in Nature magazine. There was a recent global conference of geneticists. A few days after that geneticist conference, where these people were in, talking with each other, meeting with each other, about 20 of them got a tweet. The tweet was from one of those geneticists. The tweet said, I'm in the ICU. Guess why? Wait for it. I've got serious COVID-19. Now, one of the 20 geneticists that saw that and realized that I've been breathing that person's air for hours every day within less than 6 feet because none of us knew that we had it. So therefore, we all thought that we were safe. That person, by the way, had just been to visit her 80-year-old father and mother, one of whom had some significant disabilities in this space. So it's like, that's where the transmission's coming from. It's coming from people that don't know that they have it. So please be careful and start thinking a little bit harder about social isolation and, quote, it's not in my world, so I don't have it. Well, just wait over the next 2 weeks. I think we're going to continue to see the outcome of that kind of thinking. I don't have any kids at home, so I'm not likely to get the virus. Well, again, I mean, kids, I mean, as we're seeing and as we know, kids are probably a significant link in that chain, but this is not all just kids. They're just a link in the chain. And I think even if you break the kids link in the chain, I don't think that's going to have a significant impact on, well, that's not going to stop transmission of this virus. So not having kids at home is not a protection against COVID-19. Let me put it that way. Maybe I've misworded something that can be misinterpreted. I don't think that kids are I'll leave it at that. My daughter just came home from spring break. I can't isolate her during family meals. Well, why not? And she was out at spring break. She was interacting with a whole bunch of people, many of whom probably had the virus and most of whom didn't know it. She may have the virus and we don't know it yet. So tell me again why you can't isolate her. I have only 3 or 4 people over to my house at once. Okay. You know, that reminds me of, you know, all of these questions and scenarios remind me of the Clint Eastwood movie. Are you feeling lucky? Because again, I mean, these people that didn't have the disease are the ones that are spreading it right now, or didn't know that they had the disease. I use hand sanitizer when I go out, and do I hand my credit card over to the cashier? Yeah, I mean, Janice is very proud of herself. She went over to pick up some medications the other day, and I wasn't so happy with her because I had some medications I'm going to have to pick up over the next week or so. And my perspective was, wait a week, let's make one trip with one of us instead of 2 or 3. And she said, oh no, I didn't hand the person my credit card, so I'm being smart. Not handing them a credit card is being smart, but can we plan a little better? I mean, we should be able to go to the grocery store and the pharmacy once a month right now. For us old baby boomers in our 60s with diabetes, prediabetes, heart disease, etc. I'm fine walking outside with other people. It's going to warm up, isn't it? Well, I think for the most part, I've had several people say, well, why can't I go out and walk? I don't see why you can't. I don't think going out and walking is a significant risk. It's not like you're going to be breathing other people's air. I mean, I wouldn't be walking hand in hand with a stranger. I would only be walking with somebody that's in my home already, and I'm therefore already exposed to. So, oh, and it's going to warm up, so we're fine. No, we're not. Let's go back to flu transmission as a model here. Flu is, you do see significant decrease of flu transmission during the summer areas, especially if you live in colder places like New York. But it doesn't stop during the summer. You get flu transmission during the summer. And guess what? In the tropics, you don't have a flu season. You just get continued flu transmission. And guess what? Look at Thailand. Look at Thailand and COVID transmission right now. And I think you'll get your answer on this pipe dream that summer's going to wipe out the coronavirus pandemic. Let's don't rely on that. That's not a good plan. Okay, so let's go to some other questions. We've got a lot of them. We've got a lot of participation. I'm obviously not going to get to all of them, but again, a lot of very interesting participation, and I certainly appreciate it. Candesartan and epicynamine, your take. Again, oh, I don't think I did. Did I talk about ACE inhibitors and ARBs? I don't think I did. I've got a lot of people on ACE inhibitors, and there's a lot of people on ARBs. In our practice, we tend to switch people from ARBs to ACEs if possible. For those of you who are not familiar with that, ACE inhibitor, angiotensin converting enzyme inhibitor, ARB, angiotensin receptor blocker. Why do those even matter? The A is angiotensin. Here's the thing. There's a receptor in our cell membrane, and it's the ACE2 receptor. That is the receptor that the coronavirus attaches to get entry into the cell. So when you start thinking about that logic, a lot of people have said, well, you know, ACE inhibitors and ARBs decrease and block that those receptors. So let's put everybody on ACE inhibitors and ARBs. Then you get other people who say, oh no, wait a minute, it acts in just the opposite direction. ACE inhibitors and ARBs cause the cell to create more ACE2 receptors. So therefore you increase your risk. And by the way, people with high blood pressure are more susceptible to this problem. So it's got to be the other way. Here's the thing, it's not known right now. So if I've got somebody that's new, that's newly developed high blood pressure that needs to go on a blood pressure medicine, I'm not recommending that they start with an ACE and an ARB because we just don't know the story on that. However, I'm not taking people off of it. I'm on an ACE inhibitor myself. I don't recommend that yet. If you look at, it started out with the European Society for Cardiology and then a couple of American societies as well. They jumped on the bandwagon and they all agreed. This is not the time to start coming off of ACEs and ARBs. And it's not the time to start putting everybody on ACE and ARBs. They've taken a look at it. Yes, they've gotten, there was even a publication in Lancet, but it was more of a letter style publication. It was an opinion. And when you actually start looking at the science, there's just not a lot there yet. Is there going to be? There might be something there. If and when that happens, yes, we will all react. Is it time to rush over to the pharmacy and stand in the waiting room, or you know, again, put yourself in that environment to make a switch that we don't know whether it's going to help or hurt or more likely not impact? No, don't do that yet. Okay, so thank you for the reminder about ACEs and ARBs. Steve Sapel, good to talk to you, Steve. Good to hear from you. How long will it be before we develop a vaccine? Here's the thing, vaccine technology has developed dramatically. I mean, I read a book, it's a very interesting book about genetics a couple of years ago on how we're getting to where we can do completed genetic analysis very quickly. And sure enough, that's already happened. There was a lab in San Diego, just so, gosh, it seems like only a couple of months ago now, but it was last week, that they had, what was his name? Francis Collins and, what's his name? The President of the United States, Donnie Trump. You had Francis Collins and Donnie Trump standing there, and the people at the San Francisco lab were presenting to them their discovery of a new vaccine. And they did it fairly quickly. They started from the genetic analysis of the novel coronavirus, COVID-19, or SARS/CoV-2. And yes, they were able to develop the amino acid sequence for a vaccine very quickly. So yes, they have that amino acid. But why don't we have it out there? Again, I mean, this is the information age. You could take that amino acid sequence and email it all over the world. They could have done that a week ago. But yet they're still saying it's going to be months, even a year or more before we get an effective vaccine. Why is that? Well, there are two problems with vaccine development at this point. Again, pardon me for itching on my face. So the first problem is we don't have vaccine production facilities located all over the world. They're still fairly sparsely populated. The bigger one, though, is this: the human trials. We can come up with proposed vaccine amino acid sequences fairly quickly these days. But what we can't do is test them in humans. And part of the problem is, I mean, we saw this, back in the 80s with one of the one of the flu vaccines caused significant neurological problems and was associated with putting a lot of people on a respirator. Again, it was something that you wouldn't have predicted and something that happens when you maybe rush vaccines too much. There was question over whether or not that really actually happened and whether the story was true. But the bottom line, it still hasn't gone away. We have to do human subject trials first, and that is what takes the time. It was a great question. Thank you very much, Steve. Will the virus abate on its own after a period of time? And what about the recurrence afterwards? Thanks. I think a lot of that remains to be seen. But what you typically see with most of these is, number one, some of these things come out with extremely high mortality rates, then they begin to drop. And the mechanism of that, a lot has to do with just numerator and denominator medicine. In other words, when a virus comes out, you don't know what to look for in asymptomatic or cases with very little symptoms, then all you see is the deaths. And so the death rate is really high. After you begin to start doing mass testing, you start finding out what the denominator actually was. In other words, this many deaths out of how many infected. Once you start finding that, those asymptomatic or low symptom infection cases, then you begin to realize the mortality rate was significantly lower than you thought coming out. Another thing that actually happens is part of the evolution of the virus. These viruses are always mutating as they go through a population. The ones that are more, that are better, better at protecting themselves and better at creating infection are the ones that get amplified. And if you kill everybody that you go into, that you infect immediately, then you're not really a good infectious agent. What you want to do is cause as few symptoms as possible so you can be transmitted. So you tend to see that more. So both of those things happen. And I think most folks who study this have an expectation that we're going to go from epidemic to pandemic, which has already happened, and then to endemic. Endemic, so epidemic is more than the usual number. That's, that can be 1 or 2 cases from a usual 0 cases, but obviously we had a bigger epidemic than that. Pandemic is having multiple cases, multiple outbreaks, multiple clusters with local transmission in multiple countries. Obviously we have that now with coronavirus, so it's a pandemic at this point. Then endemic is you have reached a certain level of almost repeatable, almost predictable, and sometimes very predictable transmission within a population. And I think that's where most of the knowledgeable expectations are, that this will become endemic. Clyde C, Brett L, here's one of Doc's video searches on YouTube, coronavirus update, accessing care during social isolation. Okay, so thanks, Clyde. Clyde is back involved in helping us on these, quote, fireside chats, by the way, and thank you very much, Clyde. You're doing some great work. James Cantor, so it's 15 milligrams of zinc with multivitamins. Yeah, is that enough? I don't know what's enough. I think, again, you get back to that same question. If you don't have an ionophore going on, you can really cram a lot of zinc into your bloodstream, but you got to have something to get it from the bloodstream into the cell. And that, again, is where chloroquine, and especially hydroxychloroquine, comes in. What I didn't mention was we covered a clinical trial. I think it was specific to coronavirus. It was clearly specific to one of the coronaviruses, where it showed that plaquenil or hydroxychloroquine was far more effective, as in multiples, like 10 times, I think, more effective at this process than chloroquine. A. Schultz, zinc does, vitamin C, D3, selenium, vitamin E, magnesium. People forget about manganese, which may be zero usage of those. John Roby, Brett, hydroxychloroquine is used in active malaria zones. Don't see COVID spread in those areas to the degree it's happening somewhere. It's an observation. That may actually be true. I wouldn't be surprised. I do think that hydroxychloroquine is going to become a significant player. We can find out other things at this point, but my money's on hydroxychloroquine. But it gets back to the same thing with all of preventive medicine. Think about heart attacks and strokes. Do we really want to find out what's good at treating it after the fact? Or do we want to prevent it? Loretta Dillingham. Loretta, I apologize. I keep forgetting which town you're in. I know you're in Australia, but pardon me, I'm a lifelong American. I almost ended up in Australia working for the Australian counterpart of the NIH. Way back 30 years ago when I was at Hopkins, the guy came back and offered us a job. I couldn't get my wife to agree. And sure enough, later she acknowledged, she said, oh, I made a mistake. We should have gone to Australia. Thank you so much for attending, Loretta. It's good to hear from you. Joseph Page, concerned that our daily postal service mail could be contaminated and transfer virus onto our fingers. Set it down in the house. That's another thing I learned from my sweet wife. I was concerned about going to the grocery store and breathing this and breathing that and all this other stuff, and really didn't think about all these packages I was getting delivered from Amazon and US Mail. So now she has a staging system. She brings them in, she puts them in the laundry room and leaves them there for a couple of days. Then we go in, we've got a special knife that we use to open these things up. We get the packaging out of there and back into the trash. Use gloves while we're doing all that. Take the gloves off, wash them. So we've got our own little process for bringing in the mail and the Amazon. Reverend Rusty, good to hear from you, Reverend. My wife has hyperparathyroidism, but her surgery for this has been postponed. Could she have a particularly compromised immune system? I haven't really read or heard. Obviously, she could. I haven't really read or heard, though, about anything associated particularly with parathyroid issues. Joseph Page, concerned that our daily, oh, we've got that. Clyde C, please, like Dr. Brewer's stream. Oh, I agree. Clyde, thank you very much. Guys, if you have an interest and you'd like to forward this activity, please refer it. Put it on your Facebook. I don't know social media that well, but you share whatever. There's some way that you can share what we do on Facebook. Please do that. Please refer it over your friends. When they come back and take a look at these and view this, the algorithm will read it and send it out to other folks. Thank you very much for.
Oh yeah. And Doc, they can actually. I'm sorry to interrupt, but they can actually also share this YouTube video. There's a share button there. Yeah, they can share it to their friends.
Great. Thank you very much, Clyde. I think it's that little arrow right there, isn't it? Share arrow.
Yeah, that's the one. It should be on the lower right corner of the video.
Yeah, it's not on mine, but I know where he's talking about. So please take a look at that. Think about doing that, getting that information out so we can help people deal with this disease without panicking. Help them understand what to do the right thing, and save lives. That's what this is all about. I'm supposed to be retired, but as you can tell, I've got a little bit of a frenetic personality, and I can't go out and play golf for a living. I'm having a blast. I've been involved with outbreaks. I was on the governor's AIDS task force when AIDS came out, 30 years ago in Maryland. I was on the Kentucky governor's pandemic task force back with H1N1 and a couple of the other activities. So I've been working for the most part recently in my retirement on the major killers of baby boomers, major killers and disablers, heart attack and stroke. And obviously now that COVID's here, the pandemic that those of us in this space have been waiting for us, the 100-year pandemic. The last one, as most of you know, was the Spanish flu. Many of you don't know, the Spanish flu probably was not Spanish. It was probably American. It was probably formed, like all of these are, from an animal host, routine animal host, to humans. And humans are, somebody remind me of the name. It's not casual host. It's not happenstance host, but it's not the regular host. So like these viruses that are coming to us, we're not the regular host for them. Like all of these coronaviruses, SARS, MERS, and now this coronavirus, SARS-CoV-2. These are all, unless I'm mistaken, we thought that some of those were simian or ape related, but no, it looks like all of these go back to mostly endemic to the bat populations, BAT, you know, the little flying rodents. There's always been a significant association, a lot of focus and what's the word I'm looking for? Surveillance projects for these in the East, especially around China. And it's very interesting. You start looking at the things that that you eat in China and some of the Asian countries, now some of the African countries. It's always been a big deal and a big interest to eat weird foods like spiders on a stick, rats on a stick, bat soup, snakes, civets, spiny anteater or scaled spiny anteaters, exotic meats. Well, these exotic meats tend to eat other things like bats, and they tend to be sold in things like wet markets where you have all these animals piled on top of each other in cages, defecating and urinating and vomiting on each other and sharing viruses. And then the humans butcher these animals in maybe not the greatest environment and then cook them. So, but then you've been handling the raw meat, and these places have been hotbeds for transmission and transmission of viruses from other animal species to our animal species. Bart Robinson, thanks for your time and your updates. You're very welcome. Thank you for your interest, Bart. I'm going to be wrapping up in just a few minutes, so anybody with any final questions, go ahead and get them in there. Peter Vafiades, Dr. Brewer, what about quercetin and ionophores, zinc? I've read and seen the mentions on quercetin many times, Peter, and I keep meaning to do some more research on that to present something associated with it. Sorry, haven't done it yet, but yes, quercetin does appear to be a significant ionophore. I just don't have the details on it. L. Hartlaub, I think I know who that is. Thanks for taking the time to share this info, Dr. Brewer. Thank you for your interest. Can you talk about at-home treatment if we do contract the virus? Well, at-home treatment, again, it's, you get back to, oh, the topic for tomorrow. The topic for tomorrow is going to be the clinical trials on the treatments. And slide number 2 or 3 on it is, why is this important? And the answer is because there is no significant effective treatment. Remember that, and that's not unusual. I mean, you go back and you look at the flus, you look at Spanish flu, you look at HIV. A lot when these things all came out, there was no significant treatment, and there's some significant treatments for things like HIV at this point, but if you think there are significant treatments for things like the flu now, I mean, yeah, there's some flu antivirals, but they're not that really that significant. That's the state of the art with men in medicine. That's why prevention is so important. So it becomes an issue of what we call, quote, supportive care, end quote. Supportive care means supporting your body function systems so you don't go down while your immune system is fighting this off. For COVID, it's a huge immune inflammatory reaction within your body. And we covered that in the very first, I think it was the very first of our quote fireside chats, our YouTube live programs. And I referred to another group, it's called MedCram. They had a great thing on how COVID kills you. Your lungs fill up with fluid because of the inflammatory process with fluid. If you get to that point, again, we mentioned this before with testing, your face turns blue, your lips turn blue, you have chest pain, you start to lose consciousness. You get to all of those, you go to the ER, you go to the hospital, you get put on a ventilator. There's several different things they can do. Number one, put you on a ventilator. Number two, put you at what we call lower tidal volumes. These lower tidal volumes are not so inflammatory on your lungs. You're not used to that, so then they have to paralyze you. And another thing they've found out is that they flip you over on your stomach as opposed to leaving you on your back. These are all really gross things, but this is a gross disease when it gets to that level. And hopefully it helps motivate people to understand why we're saying, please don't go to the beach with thousands and millions of other people, or go out to eat dinner in restaurants. So that's for the COVID level group. COVID is the disease itself. How about for lower levels of symptoms? You just got irritated eyes, you got a cold, you got pharyngitis. Then just take care of yourself. As we've said, and we talked about it earlier, probably not the greatest idea to take Advil or Motrin or some of those things that people tend to take for this, because it might decrease your body's ability to develop antibodies for this. Acetaminophen is probably okay. Here's my recommendation. I'm an old, I can be old and a little bit crusty. I just say take some hot tea, lay in bed, be grumpy, watch documentaries on Amazon. Or read a book. Or you know what, even better, the best thing to do is tune in to my videos. I've got 700 of them out there available, another 200 that aren't available yet. And you can learn all about how to protect your health for the future and live another 30 years. So, Loretta Dillingham, a good question, a quick question. Where or how can we research or investigate information as to what else acts or is an ionophore? Well, you could Google ionophores. I can tell you, Loretta, I don't mean to be non-responsive to your question, but the bottom line is that's a very popular question. And anytime anything shows significant evidence of being a good ionophore for zinc, and maybe anything that might be helpful at all for this virus, it's going to hit the airwaves quickly. And I'll certainly want to cover it. Vegan for life. Prevention is very important. Diet, exercise, and never become mineral deficient. Thank you, Vegan for life. Mac Hawley, have you looked at the Fujifilm drug, Avogen? I haven't. Joseph Page, mom is 95 and frail. My mom is, I think, 89. And frail is a relative term. She's pretty spunky for somebody in her late 80s. Anyway, your mom is 95 and frail. If she begins to have mild cold-like symptoms, should I take her to an emergency room without waiting for the more serious symptoms? I don't think that's the advice at this point. I think you want to just keep a really close eye on somebody like that. Sutabu San, does sugar intake increase the likelihood of getting sick? It does appear to, despite what the ADA may have told you in the past, low carb diets do appear to be helpful. You may be referring specifically to coronavirus, and I don't think that that's the case yet. I spoke many times about my dear wife. She just interrupted to tell me to get off the channel. I will in a few minutes once we're finished with some of these questions. Vegan for life, Joseph Page, your mom needs fluid, veggies, a good multivitamin and minerals. Mohammed Al-Aradi, How long for the drug trials to be completed? Anything promising? The answer is some of those drug trials, I'll report tomorrow night. They're in the, they were in the New England Journal this past week, and the answer on those is not very promising. Al Obaidius. Can people show no symptoms yet they carry the virus? Absolutely. Al, I'm glad you asked that. And we've talked about that many times, but again, that's the biggest issue. That is what's causing a lion's share of this pandemic transmission at this point. If there's one warning to get out there, it's the people that have no symptoms. They don't think they have the disease, yet they're spewing it. They're spewing it into the air. It survives in the air. You breathe it, you get infected, and you become a member of that chain of asymptomatic transmitters. Mac Hawley, Ibogaine was used in 200-person Chinese COVID-19 trial. The buzz is that it could cut sick days from 11 to 4. It cut acute symptoms by 90%. Thank you very, very much, Mac. I'll take a look. Can Mucinex help symptoms? Probably. Vegan for Life, love your channel. Thank you, Vegan for Life. Thank you to the rest of you. It's been a lot of fun. And thanks for your interest. Join us again tomorrow. Oh, what we're going to do, I talked with Clyde, and we're looking to making this more of a reliable 11 a.m. U.S. Eastern Standard Time event. So join us tomorrow. We'll talk about those clinical trials, the antivirals. Okay, thanks very much. See you tomorrow.